Welcome to the deep dive. Today we're embarking on quite an in-depth exploration of Chapter 281, Arterial Diseases of the Extremities.
That's right.
Our goal really is to cut through the complexity, giving you that professional level understanding of this, well, really vital medical topic.
Mm,
Think of this as your ultimate guide, distilling clinical research, guidelines, expert consensus,
yeah.
all into clear, actionable insights.
And the material for this deep dive is incredibly rich. I mean, it covers everything from systemic inflammation affecting the big arteries right down to localized issues in the arms and legs.
Yeah.
And even how our bodies react to things like cold or other environmental factors. We'll connect the dots on how these diverse conditions show up, how they're diagnosed, and of course, how they're treated.
Exactly. Providing you with a robust framework for, well, truly mastering this knowledge.
Hmm.
Our mission is to give you that insider's perspective, making sure you're not just informed, but, deeply knowledgeable. So let's jump right in and unpack the intricate world of arterial diseases. First up, we're focusing on aortitis. That's inflammation of the body's biggest and arguably most crucial artery, the aorta.
All right.
This chapter outlines a few distinct ways this critical vessel can become inflamed, each with its own sort of fascinating and often complex story.
And it's such a critical starting point because, the aorta is essentially the main highway for blood pumping from your heart out to the rest of your body.
Absolutely.
So, any inflammation here can have serious ripple effects, potentially impacting the entire arterial system.
Let's begin with rheumatic aortitis. And this isn't just, an isolated problem happening in the aorta itself.
No, not at all.
It's often a direct result of a bigger systemic battle going on inside the body.
Precisely. Rheumatic aortitis is strongly linked to various rheumatic and autoimmune diseases. We're talking conditions like rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis,
Huh.
reactive arthritis, which used to be called Reiter's syndrome, relapsing polychondritis, and even inflammatory bowel disorders.
That's a wide range.
It is. And what's particularly striking here is how these widespread inflammatory conditions, things you might typically associate with, say, joints or the gut,
Right.
can have such a profound and, frankly, destructive impact on the body's largest artery.
It's a powerful reminder, isn't it, of how interconnected our body's systems really are.
Absolutely.
The systemic nature means that inflammation isn't just stuck in one place. It can actively target major vascular structures like the aorta, often in very specific locations. The source material highlights that these inflammatory lesions usually involve the ascending aorta. That's the segment right after the heart.
Right, the first part.
And it doesn't stop there. They can extend to critical areas like the sinuses of Valsalva, the mitral valve leaflets, and even the heart muscle right next to it, the myocardium.
And this systemic involvement has severe implications. The structural damage can lead to aneurysm formation, where the aortic wall weakens and bulges out,
Okay.
or aortic regurgitation, which basically means the aortic valve doesn't close properly, so blood leaks backward into the heart.
A leaky valve, essentially.
Exactly. And there could also be direct involvement of the heart's electrical conduction system, leading to serious rhythm disturbances.
So the key takeaway is this sort of silent systemic betrayal, where diseases you think are localized actually attack the main circulatory hub.
That's a good way to put it. It really demands a holistic view of patient health, looking beyond the initial symptoms.
All right, next we move into something a bit more enigmatic, idiopathic aortitis. As the name suggests, idiopathic means we. Well, we don't really know the exact cause.
Indeed. This form is characterized by inflammation in the outer layer, the adventitia, and the tissues surrounding the aorta periortic inflammation. And this leads to a noticeable thickening of the aortic wall, but without a clear underlying reason. It really highlights one of medicine's big challenges, doesn't it?
Yeah, how do you manage something when you don't know what started it?
Exactly. How do you effectively diagnose and manage it? Interestingly, this type of aortitis is often associated with abdominal aortic aneurysms and also a condition called idiopathic retroperitoneal fibrosis.
It really is a medical detective story then. When the cause is unknown, treatment often has to focus on just managing the symptoms and the inflammation itself, right?
Precisely. Patients might present with these vague constitutional symptoms, just feeling generally unwell, maybe a fever, some abdominal pain, and a specific serious complication linked to this is that retroperitoneal fibrosis you mentioned. Basically, fibrous tissue forms behind the abdominal cavity.
And that can actually block the ureters, the tubes carrying urine.
Yes, it can obstruct them, leading to hydronephrosis, which is swelling of the kidneys because urine can't drain properly.
Wow, so even without knowing the cause, the strategy is just reduce the inflammation.
That's the primary goal. Powerful anti-inflammatory steroids like glucocorticoids and various immunosuppressive agents are used to try and mitigate the damage and alleviate symptoms. It's about controlling the fire, even if you don't know exactly how it started.
Okay, let's shift gears now to something a bit more direct. Infective aortitis. This is where actual pathogens like bacteria or fungi directly invade the aortic wall.
Right. This form results from bacteria. Common culprits are Staphylococcus, Streptococcus, Salmonella, or sometimes fungi getting into the aortic wall itself.
And it often happens where the aorta is already weakened, like by plaque.
Exactly. It frequently occurs at sites of pre-existing atherosclerotic plaque. It really shows the vulnerability of already damaged vessels to infection.
Mm-hmm.
And you mentioned the term mycotic aneurysm earlier. It's a bit of a historical term because it's usually bacterial, not fungal. But it vividly describes this destructive, almost fungus-like growth pattern that can develop rapidly. It often forms a saccular aneurysm, like a sac bulging out from the wall.
And the mechanism is pretty destructive, right? Bacterial enzymes breaking down the collagen?
Yes, bacterial proteases degrade the collagen, essentially destroying the aorta's structural integrity. And this destruction leads to that saccular aneurysm forming, most often in the suprarenal abdominal aorta, the part just above the kidneys.
And pathologically, what does the wall look like?
You'll see signs of both acute and chronic inflammation, abscesses, bleeding, hemorrhage, and even tissue death, necrosis. It's a real mess.
Demographically, who does this tend to affect?
Typically the elderly,
Mm.
and men are about 3 times more likely to develop these than women.
And the presentation, how do patients usually show up?
Usually with clear signs of infection, like fever and sepsis, along with pain, chest, back, or abdominal pain, depending on where the aneurysm is. A crucial diagnostic clue. Sometimes there might have been a preceding diarrheal illness, especially if Salmonella is the bug involved. And most patients will have positive blood cultures, confirming that bacterial invasion.
So diagnosis involves imaging like CT and MRI?
Correct. CT and MRI are key to visualize the aneurysm. And treatment is absolutely critical. It's urgent. It involves aggressive antibiotic therapy to fight the infection,
Right.
followed by surgical removal of the infected part of the aorta. Then comes the challenge of restoring blood flow safely.
Revascularization, right. Putting grafts in clean tissue.
Exactly. Placing grafts, usually to the lower extremities, in tissue that's completely uninfected. It's a real race against time and the infection to prevent rupture or further systemic spread.
Now, for something that really hammers home the long-term impact of disease, syphilitic aortitis, this is like a delayed consequence, almost a historical echo from an infection maybe decades earlier.
Exactly. Syphilitic aortitis is a late manifestation of syphilis, the leuetic infection. It often appears decades after the initial exposure.
Decades. Wow.
Yes. It typically targets the proximal ascending aorta, particularly right at the aortic root, leading to dilation and aneurysm formation. These aneurysms can be saccular or fusiform, spindle-shaped, and are usually asymptomatic for a very, very long time.
Until they get big enough to cause problems.
Precisely. As they grow, they can compress or erode into adjacent structures, causing symptoms. And dangerously, they can rupture. It's a critical reminder for anyone taking a medical history. Past infections can have very delayed consequences.
It really highlights how these things can act like a medical time bomb, ticking away silently. The progression sounds intricate, too. It starts with the small vessels feeding the aorta.
That's right. The initial damage isn't directly to the main aortic wall itself, but to the vasa vasorum, the tiny blood vessels that supply the aorta's outer layers. It's like syphilis chokes off the aorta's own little supply lines.
Leading to inflammation and damage there first.
Correct. Over time, the infection spreads deeper into the media layer, destroying the crucial collagen and elastic fibers that keep the aorta strong and flexible.
And that structural breakdown leads to the widening, the aneurysm formation, scarring, calcium buildup.
Exactly. And that often gives us a very characteristic clue on X-rays. A linear calcification, almost like a hard shell, along the ascending aorta. It reveals decades of silent damage.
So it often shows up incidentally on a chest X-ray, maybe 15, 30 years after the infection.
That's typical. Symptoms, when they finally emerge, can stem from aortic regurgitation, the leaky valve again.
Right.
Narrowing of the openings to the coronary arteries because of the aortitis, compression of nearby structures like the esophagus, or, most severely, aneurysm rupture.
And diagnosis is confirmed with blood tests for syphilis.
Yes, a positive serologic test like the RPR or a fluorescent treponemal antibody test. Treatment then has to focus on both managing the underlying, maybe latent infection, and dealing with its severe vascular consequences.
Okay, now we shift our focus away from the central aorta and look at the arteries supplying our limbs. This is peripheral artery disease, or PAD. It's incredibly common, yet as the material points out, often goes undiagnosed. And it carries significant risks far beyond just, leg pain.
This is such a critical area. PAD is defined basically as a clinical disorder. There's narrowing, stenosis, or a complete blockage, occlusion, in the aorta or the arteries of the limb.
Right.
Now, for patients over 40, atherosclerosis, hardening of the arteries, is overwhelmingly the leading cause. But it's not the only one.
What else can cause it?
Other factors include blood clots, both forming locally, thrombosis, and traveling, embolism, various types of vasculitis, that arterial wall disorder, fibromuscular dysplasia we'll touch on later, anatomical entrapments, cystic adventitial disease, and trauma.
Okay, so why is PAD so often under-recognized then?
That's a crucial question the material raises. It's vital for you, the listener, to understand that PAD isn't just a leg problem. It's a major red flag for systemic atherosclerotic disease.
Meaning plaque buildup elsewhere.
Exactly. It dramatically increases the risk of heart attack and stroke. So really, treating the legs means treating the whole person, the whole cardiovascular system.
That's a really important point about its systemic nature, and it mostly affects older people.
The highest prevalence of atherosclerotic PAD occurs in people in their 60s and 70s. And critically, it shares the exact same risk factors as atherosclerosis, affecting the heart and brain.
Like smoking.
Cigarette smoking is a primary driver. Also, diabetes mellitus, high cholesterol, hypertension, and renal insufficiency. If you have these risk factors, especially smoking or diabetes, your risk for PAD is significantly higher. Now, when we look at the pathology, what's actually going on in the artery, we see these segmental lesions causing the narrowing or blockage. They're usually localized to large and medium-sized vessels.
Okay.
The pathology itself involves those atherosclerotic plaques, often with calcium deposits. You see thinning of the media, that middle muscular layer, patchy destruction of muscle and elastic fibers, fragmentation of the internal elastic lamina, a key structural layer, and clots made of platelets and fibrin. It's really a complex breakdown of the vessel's whole architecture.
And it's not just random blockages, right? They tend to form in specific places.
That's right. These atherosclerotic lesions preferentially form at arterial branch points. These are areas where blood flow is more turbulent, creating higher shear stress. It's almost like an engineering flaw in our body's plumbing.
Interesting. And where do we typically see these blockages in patients who have symptoms?
There are distinct patterns. The abdominal aorta and the iliac arteries, the ones branching into the legs, are involved in about 30% of symptomatic patients.
Okay.
The femoral and popliteal arteries, further down the leg, are involved in a huge majority, 80 to 90% of patients.
Wow, that's high.
And then the more distal vessels, the tibial and peroneal arteries down by the ankle and foot, are involved in maybe 40 to 50% of patients. Understanding how PAD actually manifests itself is absolutely key for early diagnosis. And what stands out to me is how the location of the pain often gives you a really good clue about where the blockage might be.
Oh, like a roadmap.
Exactly, a critical diagnostic clue. And the spectrum of symptoms, ranging from completely silent to critically limb-threatening, really underscores why a thorough physical examination and, just as importantly, attentive listening to patient complaints are so vital.
It's surprising, isn't it, that fewer than half of people with PA are actually symptomatic?
It is, though many might have subtle signs, like a slow or impaired gait they don't even realize is related.
Right. But for those who do get symptoms, the most typical one is intermittent claudication. Can you unpack that?
Sure. Intermittent claudication is defined as a pain, an ache, a cramp, numbness, or maybe just a sense of fatigue in the muscles. The key is that it occurs during exercise and is reliably relieved by rest.
And the location matters.
Critically, the site of claudication is always distal to or downstream from the occlusive lesion. So, for example, buttock, hip, or thigh discomfort points towards aortoiliac disease higher up.
Okay.
Whereas calf claudication, which is very common, usually develops in patients with femoral popliteal disease lower down. And symptoms are far more common in the lower extremities than the upper, simply because obstructive lesions are more frequent there.
What about more severe cases?
Well, for patients with severe arterial occlusive disease, where the blood flow arrest isn't even enough to meet the basic nutritional needs of the tissues, critical limb ischemia, or CLI, can develop.
And how does that present?
These patients complain of pain at rest or a feeling of cold or numbness, usually in the foot and toes. Interestingly, these symptoms often occur at night when the legs are horizontal.
Ah, less gravity helping.
Exactly. And they often improve when the legs are put in a dependent position, hanging down. With truly severe ischemia, though, this rest pain can become persistent and quite agonizing.
And the physical examination, what clues can that give us?
Several important ones. You might feel decreased or even absent pulses distal to the obstruction. You might hear bruits, that whooshing sound over narrowed artery with a stethoscope. And you might see muscle atrophy, muscle wasting.
Visible signs, too.
Yes, with more severe disease, there are often visible changes. Hair loss on the legs or feet, thickened toenails, smooth and shiny skin, reduced skin temperature, and the skin might look pale, pallor, or bluish, cyanosis.
And in CLI?
In CLI, you might see ulcers, especially on the toes or pressure points, or even gangrene, which is tissue death. These signal severe tissue damage.
You mentioned provocative maneuvers earlier. What are those?
Right. These are things we can do during the exam to uncover signs that might not be obvious at rest. For example, elevating the legs and having the patient repeatedly flex their calf muscles can cause the soles of the feet to become quite pale.
Okay.
Then, when the legs are lowered back down, a marked redness or rubor might develop. This is due to reactive hyperemia, a rush of blood trying to get back into the deprived tissues.
And the timing tells you something.
Yes, the time it takes for that rubor to appear, or for the veins in the foot to fill up again when the legs go from elevated to dependent, that's related to the severity of the ischemia and how well developed any collateral or bypass vessels are.
Any other signs?
Patients with severe ischemia might develop peripheral edema, swelling, partly because they tend to keep their legs hanging down much of the time to ease the pain.
Makes sense.
And ischemic neuropathy can cause numbness and diminish reflexes, hyperreflexia.
So it sounds like you can gather a lot of information just from the history and the physical exam, often enough for a diagnosis, which is great.
Often, yes. But to objectively confirm the presence and, importantly, the severity of PNA, we rely on several non-invasive techniques.
Okay, what's the main one?
The ankle brachial index, ABI, is absolutely crucial. It's a simple ratio. We use standard blood pressure cuffs and a Doppler device to measure the systolic pressure at the ankles and in the arm, the brachial artery.
Then what's normal?
Normally, the ankle pressure is similar to or slightly higher than the arm pressure. So the ratio, the ABI, is between 1.00 and 1.40.
What abnormal?
Values between 0.91 and 0.99 are considered borderline. An ABI below 0.90 is diagnostic of PA.
What if it's really high, like over 1.40?
Ah, that's interesting. An ABI above 1.40 usually suggests non-compressible arteries. This happens when the vessel walls are heavily calcified, often seen in advanced atherosclerosis or in patients with diabetes. The cuff just can't squeeze the artery shut properly.
Got it. What other non-invasive tests are used?
Beyond the ABI, we can do segmental pressure measurements. We place cuffs at different levels along the leg, thigh, calf, ankle to detect pressure drops or gradients between segments. That helps pinpoint where significant stenosis might be.
Okay.
Segmental pulse volume recordings look at the waveform of the pulse. The amplitude gets blunted or flattened in the presence of significant PA. Duplex ultrasonography is very useful. It combines B-mode imaging to actually see the artery with Doppler flow analysis to assess blood velocity. It can directly visualize lesions in native arteries and also check the status of bypass grafts.
Any others?
Transcutaneous oximetry, which measures oxygen levels right on the skin surface, can give an idea of tissue perfusion. And treadmill stress testing is valuable.
How does that help?
It allows an objective assessment of the patient's functional limitations. How far can they actually walk before the claudication starts? Plus, measuring the ABI immediately after exercise is key. A significant drop in the ABI post-exercise provides further support for the diagnosis of PA, especially in patients where the symptoms or resting findings are a bit ambiguous.
No, what about the more advanced imaging, like MRA or CT scans?
Right, it's vital to make a distinction here. Modalities like magnetic resonance angiography, MRA, computed tomographic angiography, CTA, and the traditional conventional catheter-based angiography. These are not for routine diagnostic testing for PA.
So when are they used?
They are reserved specifically for planning purposes before a potential revascularization procedure, whether it's endovascular or surgical. They provide the detailed anatomical map needed to plan the intervention safely and effectively.
Okay, now let's talk about the prognosis and the risks associated with PA. This is a really critical takeaway for you, the listener. If you or someone you know has PA, it's absolutely not just about leg pain.
No, it's much bigger than that.
It's a major red flag for widespread arterial disease throughout the body, and this makes aggressive risk factor management absolutely paramount. It's really a systemic warning sign.
That's the core message, absolutely. The natural history, the long-term outlook for patients with PA is primarily influenced by the extent of coexisting coronary artery disease, CA, and cerebrovascular disease. It acts almost like a barometer for their overall vascular health.
Statistics are pretty sobering, aren't they?
They are. Approximately one-third to one-half of patients who have symptomatic PID also show clinical signs or ECG evidence of coronary artery disease. And if you do coronary angiography on them, over half have significant CAD.
Wow, that's a huge overlap. And it impacts mortality.
Significantly. Patients with PA have a 15–25% mortality rate over 5 years. And they have a 2- to 4-fold increased risk of death, specifically from cardiovascular disease compared to those without PA.
And the ABI matters here, too.
Yes, the ABI isn't just diagnostic, it's also prognostic. Mortality rates are highest in those patients with the lowest ABI values.
What about the PA itself? Does it tend to get worse over time?
Approximately 20–25% of patients with PA will experience progression of their disease over a period of 5 years.
And the risk of developing critical limb ischemia?
Around 11% of patients with symptomatic PA ultimately develop CLI. And once CLI develops, the outlook is quite concerning. 25–30% of patients with critical limb ischemia undergo amputation within just 1 year.
That's a high rate. Are there factors that make the prognosis worse?
Yes, definitely. The prognosis is significantly worse in patients who continue to smoke cigarettes or those who have diabetes mellitus. It just underscores, again, the vital importance of managing those specific risk factors.
Okay, so managing PAD sounds like it requires a really comprehensive and individualized approach. There seem to be a lot of tools in the medical toolbox.
There are.
It's clear that treating PAD requires combining lifestyle changes, medications, and sometimes, very sophisticated procedures. The key message for you, the listener, seems to be catching it early and managing those risks diligently.
Absolutely. The overall goals of management are multifaceted. We want to reduce the risk of associated cardiovascular events like heart attack and stroke and death. We want to improve the limb symptoms like claudication. We need to prevent progression to critical limb ischemia and ultimately preserve limb viability, avoid amputation.
So where do you start? What's foundational?
The absolute cornerstone is cardiovascular risk factor modification. And number 1 on that list is smoking cessation.
You really can't overemphasize that, can you?
You cannot. Discontinuing cigarette smoking is paramount. The physician has to play a major role here with counseling and using adjunctive drug therapies like the nicotine patch, bupropion, or varenicline to boost cessation rates and reduce relapse.
What about blood pressure?
Equally vital. Blood pressure control in hypertensive patients is crucial. Angiotensin-converting enzyme inhibitors, ECE inhibitors, and angiotensin receptor blockers, ARBs, may reduce the risk of cardiovascular events in patients with symptomatic P8.
Are beta blockers okay? Some people worry they worsen claudication.
That's a common concern, but the evidence shows that beta-adrenergic blockers do not worsen claudication, and they can, and often should, be used to treat hypertension, especially in patients who also have coexistent coronary artery disease.
Good to know. And cholesterol.
Hypercholesterolemia is another major target. Aggressive treatment with statins is essential. And if needed, adding adjunctive lipid-lowering agents like ezetimibe or a PCSK9 inhibitor is advocated to reduce the risk of myocardial infarction, stroke, and death.
There are specific goals for lowering LDL.
Yes. The 2018 AAACC guideline recommends high-intensity statin treatment in all patients with atherosclerotic disorders, including PA, with the aim of achieving a 50% or greater reduction in low-density lipoprotein cholesterol. It reflects that intense focus on broad cardiovascular protection.
Okay, so risk factors are key. What about preventing clots, antithrombotic therapy?
Yes, preventing clots is paramount in these patients. Platelet inhibitors like aspirin and the adenosine diphosphate ADP antagonist clopidogrel are foundational. They reduce the risk of adverse cardiovascular events in anyone with atherosclerosis.
So they're recommended for most PAD patients?
Yes, recommended for patients with symptomatic PAD, including those with intermittent claudication or critical limb ischemia, or those who've had prior lower extremity revascularization. Another drug, ticagrelor, offers similar outcomes to clopidogrel.
What about using both aspirin and clopidogrel together? Dual antiplatelet therapy.
That's a good question. The benefit of dual antiplatelet therapy compared with aspirin alone, and specifically reducing cardiovascular morbidity and mortality rates in patients with PAD, is actually uncertain. It's not as clear-cut as in some other conditions like recent coronary stenting.
Are there other antiplatelet options?
There's Vorapaxar. It's a protease-activated receptor 1 antagonist, inhibiting thrombin-mediated platelet activation. When added to other antiplatelet therapy, it does decrease the risk of adverse cardiovascular events in patients with atherosclerosis, including PAD.
Does it help the legs specifically?
Yes, it also reduces the risk of acute limb ischemia and the need for peripheral revascularization. However, and this is a big however, it is associated with an increased rate of moderate bleeding, so it's a risk-benefit calculation.
What about anticoagulants like warfarin?
The anticoagulant warfarin, while effective in preventing adverse cardiovascular events, causes significantly more major bleeding compared to antiplatelet therapy. Therefore, it is not indicated to improve outcomes in patients with chronic PAD.
But there's a newer approach with a different anticoagulant.
Yes, the combination of a low dose of the oral factor SAN inhibitor rivaroxaban plus aspirin has shown promise.
How so?
This combination improves both cardiovascular and limb outcomes in patients with established atherosclerosis, including PAD, and that includes those who've already undergone peripheral revascularization. But, again, similar to Vorapaxar, it is associated with an increased risk of bleeding. It highlights that constant balancing act between preventing clots and causing bleeding.
Okay, so that covers systemic risk reduction and antithrombotics. What about therapies specifically for the leg symptoms like claudication or CLI?
Right. Supportive measures are really fundamental here. Things like meticulous care of the feet, keeping them clean, protected against excessive drying with moisturizing creams.
Shoes matter too.
Definitely. Well-fitting and protective shoes are advised to reduce trauma. And importantly, patients should avoid elastic support hose as they can actually reduce blood flow to the skin.
What about for critical limb ischemia pain?
For patients with CLI, simple measures like putting shock blocks under the head of the bed to elevate it slightly, along with using a canopy or cradle over the feet to keep bedding off them, may help improve symptoms, especially rest pain.
And exercise. You mentioned that earlier.
Exercise training is a highly effective non-pharmacologic intervention. Patients should be encouraged to walk regularly and at progressively more strenuous levels as tolerated.
Are supervised programs better?
Supervised exercise training programs, typically 30 to 45-minute sessions, at least 3 times per week for 12 weeks, have been shown to significantly prolong walking distance. The beneficial effect on walking performance is often similar to, or sometimes even greater than, what's achieved after a revascularization procedure.
Wow, that's impressive. What if supervised programs aren't available?
Structured home and community-based exercise programs have also been shown to be effective. The key is structured, regular activity.
Now, what about medications specifically for claudication? Are they very effective?
Honestly, pharmacologic treatment of PAD symptoms hasn't been as successful as treatments for, say, coronary artery disease. Vasodilators as a class, things like alpha-adrenergic blocking agents or calcium channel antagonists, have generally not been shown to be effective in patients with PAD for improving claudication.
Are there any exceptions?
One notable exception is cilostazol. It's a phosphodiesterase inhibitor with both vasodilator and antiplatelet properties. It can increase claudication distance by about 40–60% and also improves measures of quality of life. Interestingly, the exact mechanism behind its beneficial effects isn't fully known.
Any others?
Pentoxifalane is another drug sometimes used. It's a substituted xanthine derivative thought to increase blood flow to the microcirculation and enhance tissue oxygenation. While some studies showed modest increases in exercise duration, its efficacy hasn't been consistently confirmed in all clinical trials.
What about statins? Do they help claudication direct?
Statins, while absolutely crucial for overall cardiovascular risk reduction, appeared effective for treating intermittent claudication in some initial clinical trials. But more studies are needed to confirm that specific benefit.
Okay, what about medical therapy for the most severe form, critical limb ischemia?
Unfortunately for CLI, there's currently no definitive medical therapy that's widely proven effective in terms of saving limbs. Vasodilator prostaglandins, for example, are not effective in relieving symptoms or preventing limb loss in CLI.
What about things like growth factors to stimulate new blood vessels?
There was a lot of enthusiasm initially for therapy with angiogenic growth factors using intramuscular gene transfer of DNA encoding things like VEGF, FGF, or HGF. However, that enthusiasm really abated when large clinical trials failed to demonstrate improvement in symptoms or outcomes.
And stem cells.
Similarly, using bone marrow-derived vascular progenitor cells to promote angiogenesis and preserve limb viability. Most clinical trials have failed to demonstrate a clear benefit, although one meta-analysis did suggest a modest reduction in the risk of amputation. So it's still an area of research.
So if medical therapy and exercise aren't enough, that's when revascularization comes in, opening up the blockages.
Exactly. Revascularization procedures, both catheter-based, endovascular, and traditional surgery, are usually indicated for patients with disabling, progressive, or severe symptoms of intermittent claudication, despite optimal medical therapy. The goal there is to improve walking distance and functional capacity.
And for CLI.
And they're definitely indicated in patients with critical limb ischemia, where the primary goals are to relieve rest pain and, crucially, prevent limb loss.
And you need detailed imaging before these procedures.
Yes. Before any revascularization is considered, MRA, CTA, or conventional angiography should be performed to assess the vascular anatomy precisely and help plan the intervention.
Let's talk about the endovascular interventions first. What do those include?
These are the catheter-based techniques. They include percutaneous transluminal balloon angioplasty, PTA, just stretching the artery open with a balloon,
Right.
which now also includes drug-coated balloons designed to prevent re-narrowing. They also include stent placement, putting in a metal scaffold to hold the artery open, and these can be bare metal or drug-eluting stents, also releasing medication. Other options are stent grafts, which are covered stents, and atherectomy, which actually removes plaque from the artery wall.
Do these improve walking distance?
Yes, when performed in conjunction with a supervised exercise program, walking distance improves more than with exercise training alone.
How successful are they? Does it depend on where the blockage is?
Yes, success rates vary by location. PTA and stenting of the iliac artery, higher up, are associated with higher success rates, roughly 90–95% initial success, and over 75% patency, meaning staying open, at 3 years.
And lower down.
PTA and stenting of the femoral and popliteal arteries have slightly lower long-term success, around 90% initial success, but maybe only 60% 3-year patency. Patency rates might be higher if a stent is placed in the iliac artery compared to just balloon angioplasty.
What about those drug-coated devices? Do they help prevent restenosis?
Several clinical trials have found lower femoral popliteal restenosis rates with drug-coated balloons compared to standard PTA, and also with drug-eluting stents compared with bare metal stents in that region.
There was a concern raised about them.
Yes, a crucial note. Recent meta-analyses have raised concerns about potentially increased mortality in patients treated with paclitaxel drug-coated balloons and stents. This is an ongoing area of investigation and has led to more caution in their use, requiring careful patient selection and discussion.
And these techniques can be used for CLI too, even in smaller vessels.
Yes, endovascular interventions of the infrapopliteal, tibial, and peroneal arteries, the vessels below the knee, often done in conjunction with treating more proximal lesions, are specifically used to treat critical limb ischemia and prevent limb loss.
Okay, now what about surgical procedures? Open surgery.
Right. Several operative procedures are available, and the choice depends on the location and extent of the obstruction, as well as the patient's overall medical condition.
For blockages higher up in the aorta or iliac arteries.
For aortoiliac disease, the most frequently used procedure is aortopefemoral bypass. This involves placing a Y-shaped graft, usually knitted Dacron, from the aorta down to both femoral arteries in the groin.
How well do those work?
They have impressive patency rates, about 99% immediate patency, over 90% at 5 years, and still over 80% at 10 years in patients who survive that long. Other surgical options for this area include axillofemoral bypass, femoral bypass, and aortoiliac endarterectomy, which involves cleaning out the plaque.
Are there significant risks with these major surgeries?
Yes, surgical complications for aortoiliac procedures can include myocardial infarction and stroke, graft infection, peripheral embolization, debris going downstream, and sometimes sexual dysfunction due to interruption of autonomic nerves in the pelvis. Operative mortality ranges from 1% to 3%, mostly due to underlying ischemic heart disease.
And for blockages lower down in the femoral popliteal or tibial arteries.
For femoral popliteal and tibioperoneal artery disease, the procedures often involve using the patient's own saphenous vein for bypass grafts, either in situ, left in place but valves destroyed, or reversed. Alternatively, synthetic grafts made of polytetrafluoroethylene, PTFE, or other materials could be used, or sometimes thromboangiitis. Operative mortality here is also relatively low, typically 1% to 3%.
How well do these lower leg bypasses hold up?
Long-term patency depends heavily on the graft type, where the distal end is sewn in, the anastomosis location, and the condition of the runoff vessels below the graft. Saphenous vein bypass grafts generally have better patency rates. For femoral popliteal bypasses, it's around 90% at 1 year and 70–80% at 5 years.
And even further down.
For infrapopliteal bypasses using vein, maybe 60–70% at 5 years. In contrast, using PTFE grafts for infrapopliteal bypasses has much lower patency, often less than 30% at 5 years. Vein is generally preferred when available and suitable.
Given that many PAD patients also have heart disease, assessing cardiac risk before surgery seems crucial.
Absolutely. Preoperative cardiac risk assessment is vital. It helps identify individuals who are especially likely to experience an adverse cardiac event, like a heart attack, during or shortly after the surgery. High-risk individuals include those with angina, a prior heart attack, heart failure, diabetes, or renal insufficiency.
How's that risk assessed?
Further risk stratification often involves stress testing. If the patient can walk, treadmill exercise testing is useful. Otherwise, radionuclide myocardial perfusion imaging or stress echocardiography can be used, particularly for those with poor or unknown functional capacity.
And if the stress test is abnormal,
Patients with abnormal test results require close supervision during the perioperative period and often benefit from adjunctive management with anti-ischemic medications like beta blockers.
should patients routinely get heart catheterization or bypass surgery before their vascular surgery?
That's an important point. Routine coronary angiography and coronary artery revascularization, like bypass or stenting, do not improve outcomes compared with optimal medical therapy in most patients undergoing peripheral vascular surgery.
So it's not usually necessary.
Not routinely. However, cardiac catheterization should be considered in specific situations. Patients with unstable angina, angina refractory to medical therapy, or those suspected of having very high-risk coronary anatomy like left main or three-vessel disease.
Wow, that's an incredible overview of PAD management. It really underscores the complexity and the need for that individualized approach. #3, rare and unique arterial conditions beyond atherosclerosis. So we've covered the big picture with aortitis and the very common PA, but the arterial system can suffer from a variety of other, more specific and sometimes quite rare conditions that affect the extremities, often unrelated to atherosclerosis.
Right, let's delve into some of these unique conditions now. Let's start with fibromuscular dysplasia, or FMD. You sometimes hear it called the string of beads artery.
Why that name?
Well, it's a disorder where there's abnormal growth of cells within the artery wall, a hyperplastic disorder. It typically affects medium and small arteries, though larger ones can be involved too. And it predominantly affects females. What's fascinating, and gives it that name, is the characteristic appearance on angiography.
Okay.
It reflects these alternating areas of normal and thin vessel wall, creating turbulent blood flow. This structural issue, fundamentally different from plaque buildup, can lead to a host of complications.
A truly distinctive pattern, then. Where does FMD usually occur?
It commonly involves the renal arteries, affecting blood flow to the kidneys, and the carotid or vertebral arteries going to the brain. But it can also affect coronary arteries, mesenteric arteries supplying the gut, and, relevant to our discussion, extremity vessels like the iliac and subclavian arteries.
And the outcomes can be serious.
Yes, FMD may cause stenosis, narrowing, dissection, a tear in the artery wall, aneurysm formation or thrombosis, clotting in the affected arteries.
What's happening at the cellular level?
Histologically, it involves different layers. Medial dysplasia is the most common type, affecting the middle muscular layer. You see alternating areas of thinned media and these fibromuscular ridges, usually with a key structural layer, the internal elastic lamina, still preserved. That cellular arrangement directly creates the angiographic look.
Right. So imaging classifies it based on that appearance.
Yes, a contemporary classification based on angiographic appearance divides FMD into multifocal, which is analogous to that medial dysplasia with the beads and focal, which looks more like a single area of narrowing, often due to intimal fibroplasia.
And in the limbs?
The iliac arteries are the limb arteries most likely affected, identified angiographically by that classic string of beads, multifocal appearance, thickened ridges next to thin, less involved parts of the artery wall.
And the symptoms?
Clinically, patients might experience symptoms similar to PA, like claudication and rest pain, depending on which arteries are involved and how severely. Treatment often involves percutaneous transluminal angioplasty, PTA, to stretch open the narrowed areas. And sometimes surgical reconstruction is needed for debilitating symptoms, or if the limb is threatened.
Okay, next up is thromboangiitis obliterans, more commonly known as Buerger's disease. This one seems like a very stark, specific example of smoking's impact, especially on younger people.
It really is.
The fact that the only specific treatment mentioned is stopping tobacco, that really puts the focus squarely on that lifestyle change, doesn't it?
Absolutely. Buerger's disease is an inflammatory occlusive vascular disorder. It primarily involves the small and medium-sized arteries and veins in the distal, upper, and lower extremities, hands and feet mostly.
Can it affect other areas?
Rarely, yes.
Huh.
Cerebral, visceral, gut, and coronary vessels can sometimes be affected. It most frequently develops in men under the age of 40, and there's a higher prevalence in Asians and individuals of Eastern European descent.
And the cause? Is it just smoking?
While the precise underlying cause isn't fully known, there is an undeniable, almost absolute relationship to cigarette smoking in patients with this disorder. Tobacco cessation is the absolute cornerstone of management.
The pathology sounds quite unique, too. Inflammation involving white blood cells.
Yes. In the initial stages, specific white blood cells called polymorphonuclear leukocytes infiltrate the walls of these small and medium vessels. Crucially, unlike some other conditions, the internal elastic lamina, that structural layer, is usually preserved. But a cellular inflammatory thrombus, or clot, develops right in the vascular lumen, blocking flow.
And it changes over time.
As the disease progresses, different immune cells, mononuclear cells, fibroblasts, even giant cells replace those initial neutrophils. Later stages are characterized by perivascular fibrosis, scarring around the vessels, the organized thrombus, and sometimes recanalization, where tiny new channels try to form through the old clot.
How does it typically present clinically? Is there a classic picture?
Often, yes. It includes a triad of symptoms. First, claudication of the affected extremity, but usually confined to the calves and feet or the forearms and hands because it hits distal vessels.
Okay.
Second, Raynaud's phenomenon, those color changes with cold, which we'll discuss more soon. And third, migratory superficial vein thrombophlebitis, inflammation of superficial veins that seems to move from place to place.
What about severe cases?
In the presence of severe digital ischemia, you can see trophic nail changes, intensely painful ulcerations, and even gangrene developing right at the tips of the fingers or toes.
And the physical exam findings?
Typically, the pulses higher up, like the brachial in the arm and popliteal behind the knee, are normal, but the distal pulses radial and ulnar at the wrist, or tibial pulses at the ankle, are often reduced or completely absent.
How is it diagnosed for sure?
Imaging like MRA, CTA, or conventional arteriography is helpful. They typically show smooth, tapering, segmental lesions in those distal vessels, often with prominent collateral vessels trying to get around the blockages. Importantly, you usually don't see proximal atherosclerotic disease, which helps distinguish it from typical PAD.
Can you biopsy it?
Yes, the diagnosis can be confirmed by excisional biopsy and pathologic examination of an involved vessel, though that's not always necessary if the clinical and imaging picture is classic. And as you highlighted at the start, the treatment is stark and singular in its focus.
Right. There is no specific treatment except absolute abstention from tobacco.
The prognosis is significantly worse in individuals who continue to smoke. But frankly, results can be discouraging even in those who do manage to stop smoking completely.
Are there any other treatments used?
Arterial bypass surgery of the larger affected vessels might be used in selected instances. Local debridement of ulcers might be needed. Antibiotics can be useful if there's secondary infection, but things like anticoagulants and glucocorticoids are generally not helpful.
And if those measures fail?
Sadly, if these measures fail and gangrene develops, amputation may be required. It's a devastating consequence directly linked to smoking in susceptible individuals. Hashtag 5E. Acute vascular events of the extremities, sudden stops in blood flow.
Okay, shifting from those chronic conditions, let's now address emergencies, specifically acute limb ischemia. This is where blood flow suddenly stops, severely threatening the limb itself. Time is absolutely critical here, Rick.
Absolutely critical. Acute limb ischemia occurs when an arterial occlusion abruptly, suddenly, cuts off blood flow to an extremity. The severity of the ischemia and the viability of the limb, whether it can be saved, depend crucially on the location and extent of that occlusion.
And collaterals matter here, too.
Yes, and importantly, on the presence and subsequent development of collateral blood vessels that might be able to bypass the blockage. The main causes are usually embolism, a traveling clot lodging somewhere,
Or
thrombus in situ, a clot forming right there on a diseased vessel wall, arterial dissection, or trauma.
So, knowing how fast this happens and how severe it is, what's the key message for our listeners in recognizing this?
It really comes down to recognizing the symptoms quickly. Early intervention is absolutely paramount to save the limb and potentially the patient's life. Every hour, even minutes count in this situation. #####1. Arterial emboli, the traveling threat.
Let's talk about those traveling clots. First, arterial emboli. Where do they usually come from?
The most common sources are the heart, the aorta itself, or other large arteries upstream. Cardiac conditions that cause thromboembolism include atrial fibrillation, AFib, acute myocardial infarction, heart attack, ventricular aneurysms, cardiomyopathy, infections on heart valves, infectious endocarditis, or non-bacterial clots, rheumatic endocarditis, thrombi associated with prosthetic heart valves, and less commonly, atrial myxoma, a heart tumor.
But mostly heart problems.
Mostly. But emboli heading to the distal vessels can also originate from proximal sites of atherosclerosis, like unstable plaque breaking off, or from aneurysms in the aorta or other large vessels.
Is there any other way clots can get into the arterial system?
Less frequently, yes. An arterial occlusion can result paradoxically from a venous thrombus, like a DVT, that has entered the systemic circulation through a hole between the heart chambers, like a patent-foramen oval or another septal defect.
And where do these emboli tend to get stuck?
They tend to lodge at vessel bifurcations where arteries split simply because the vessel caliber decreases at those points. It's like a funnel. In the lower extremities, emboli lodge most frequently in the femoral artery in the thigh,
Okay.
followed by the iliac artery higher up, the aorta itself, and then the popliteal artery behind the knee or the tibioperoneal arteries lower down. #tag 2 other causes of occlusion.
Besides emboli, what else causes acute occlusion? You mentioned thrombus in situ.
Right, that's a clot forming right at a specific spot. It can occur in arteries already diseased with atherosclerosis, typically at the site of a plaque or within an aneurysm. It can also happen in arterial bypass grafts.
And trauma.
Trauma to an artery can disrupt blood flow acutely, either by causing an acute arterial thrombus to form or by physically disrupting the artery's integrity, leading to extravasation of blood into the tissues.
Can medical procedures cause it?
Yes, arterial occlusion can be a complication of arterial punctures and placement of catheters. It can also result from an arterial dissection, where a tear occurs in the inner layer and the resulting flap obstructs the artery.
Any less common causes?
Less common causes include thoracic outlet compression syndrome, which can cause subclavian artery occlusion, or entrapment of the popliteal artery by an abnormal placement of the gastrocnemius muscle head behind the knee. Also, conditions like polycythemia, too many red blood cells, and various hypercoagulable disorders increase the risk for acute arterial thrombosis.
Clinically, how does acute limb ischemia present? What are the key symptoms and signs?
The symptoms really depend on the location, duration, and severity of the obstruction. Often patients experience severe pain, paresthesia, numbness or tingling, and coldness, poikilothermia, developing in the involved extremity, typically within about an hour.
Can it get worse?
Yes, paralysis may occur with severe and persistent ischemia. Physical findings include loss of pulses distal to the occlusion, skin changes like cyanosis or pallor, mottling, decreased skin temperature, muscle stiffening or rigidity, loss of sensation, weakness, and potentially absent deep tendon reflexes.
People sometimes talk about the 6PS.
Exactly. It's a classic mnemonic.
Yeah.
Pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia, coldness. If you see those signs, acute limb ischemia should be high on your list.
Does it always present so dramatically?
Not always.
Yeah.
If acute arterial occlusion occurs in someone who already has a well-developed collateral circulation, maybe someone with chronic PAD whose bypass graft suddenly clots, the symptoms and findings might be less severe.
Like what?
They might just notice an abrupt decrease in their claudication distance, or maybe just modest pain and paresthesia. Pallor and coolness would likely still be evident, but sensory and motor functions might be generally preserved.
How is the diagnosis confirmed?
Usually the diagnosis is pretty apparent from the clinical presentation. A bedside Doppler assessment to check for peripheral blood flow is crucial. In most situations, imaging like MRA, CTA, or catheter-based arteriography is used to confirm the diagnosis and precisely demonstrate the location and extent of the arterial occlusion.
And treatment. You said time is critical.
Immediate action is required. Once the diagnosis is made, the patient should be anticoagulated immediately with intravenous heparin. This is vital to prevent the clot from propagating further downstream and to reduce the risk of recurrent embolism.
What about restoring flow?
In cases of severe ischemia of recent onset, where the limb's viability is clearly jeopardized, immediate intervention to ensure reperfusion is indicated. There are a couple of main approaches.
Like dissolving the clot?
Yes. Catheter-directed thrombolysis involves infusing clot-dissolving drugs. like recombinant tissue plasminogen activator, reteplase or tenecteplase, directly into the artery via a catheter. This is most effective when the occlusion is recent, usually less than 2 weeks old, and caused by a thrombus in an atherosclerotic vessel, an arterial bypass graft, or an occluded stent.
When else is it used?
Thrombolytic therapy is also indicated when the patient's overall condition makes surgical intervention too risky, or when smaller distal vessels are occluded, making surgical access difficult. However, meticulous observation for hemorrhagic complications is absolutely required during intra-arterial thrombolytic therapy.
Are there mechanical ways to remove the clot?
Yes, there are percutaneous mechanical thrombectomy devices that can fragment or suck out the clot. Ultrasound-emitting catheters might also accelerate reperfusion. These mechanical treatments may be used alone, but are usually used in conjunction with pharmacologic thrombolysis.
What about surgery?
Surgical thromboembolectomy, physically removing the clot, and arterial bypass procedures are generally preferred when restoration of blood flow must occur very rapidly, say within 24 hours, to prevent limb loss, or when the symptoms of occlusion have been present for more than 2 weeks, as the clot becomes more organized and less amenable to lysis.
What happens if the limb just isn't salvageable?
Sadly, amputation is necessary when the limb is clearly not viable. This is characterized by complete loss of sensation, paralysis, and the absence of any Doppler-detected blood flow in both arteries and veins.
And long-term treatment after an event?
Long-term anticoagulation is usually indicated when the acute limb ischemia resulted from a cardioembolic source, like atrial fibrillation, prosthetic heart valves, or an atheroembolism. In some cases, surgical intervention might be needed later to remove the underlying cause, like excising an atheroembolism.
Okay, that covers the big clots, but there's another cause of limb ischemia mentioned. Atheroembolism. You called it microdebris mayhem.
Chuckles. Yes, that seems fitting.
It sounds tricky. Unlike a single big clot, this is like a shower of tiny debris, making treatment really challenging.
That's exactly right. Atheroembolism is another cause of limb ischemia where multiple small deposits of fibrin, platelets, and cholesterol debris embolize, breaking off from proximal atherosclerotic lesions or aneurysmal sites. Large, protruding aortic atheromas, unstable plaques in the aorta are a common source.
And it can cause more than just limb problems.
Yes, these microembolies can potentially lead to limb ischemia, stroke if they go to the brain, and renal insufficiency if they go to the kidneys. It can also occur, sometimes iatrogenically, after intra-arterial procedures like angiography or stenting.
How does it present differently from a large clot? You mentioned pulses.
A key characteristic is that since these atheroemboli tend to lodge in the small vessels of the muscle and skin and may not occlude the large arteries, distal pulses usually remain palpable.
Ah, that's a big difference. So what do patients complain of?
They typically complain of acute pain and tenderness, specifically at the site of embolization. Digital vascular occlusion can result in ischemia and the classic blue toe syndrome, where one or more toes suddenly appear purplish blue.
Can it lead to tissue loss?
Yes, digital necrosis and gangrene may develop. You might also see localized areas of tenderness, pallor, and livido reticularis, that net-like skin discoloration we'll discuss later, at the sites where these emboli have landed.
How do you confirm the diagnosis?
A skin or muscle biopsy from an affected area may actually demonstrate cholesterol crystals within the small vessels, confirming the diagnosis.
And treatment, you said it's difficult.
Ischemia resulting from atheroemboli is notoriously difficult to treat. Management often involves local foot care, keeping the areas clean and protected. Occasionally, amputation of a toe or part of the foot may be needed to treat necrotic areas. Analgesics are important for pain relief.
What about revascularization or clot busting?
Usually, neither surgical revascularization procedures nor thrombolytic therapy is helpful. This is because of the multiplicity, the composition, it's not just clot, and the distal location of these emboli in very small vessels.
Do medications like antiplatelets or statins help prevent it from happening again?
That's uncertain. While antiplatelet drugs and statins clearly improve overall cardiovascular outcomes in patients with atherosclerosis, it's not established whether either class of drugs specifically prevents recurrent atheroembolism. Similarly, it's not known whether anticoagulant therapy is effective.
So what can be done if it keeps happening?
Sometimes, endovascular or surgical intervention to exclude or bypass the atherosclerotic vessel or aneurysm that's identified as the source of the recurrent atheroemboli may be necessary. Basically, you try to eliminate the source of the debris, #V structural and compressive syndromes, when anatomy causes trouble.
Okay, so far we've talked mostly about problems within the blood vessels, inflammation, plaque, clots. But sometimes it's not the blood or the vessel wall itself that's the primary problem. It's the physical pathway the vessel takes. These next conditions are more about vessels getting squeezed or maybe misformed by the structures around them.
That brings us nicely to thoracic outlet compression syndrome, or TOCS. You called it the neck-shoulder squeeze, which is pretty descriptive.
Chuckles, yeah.
It's basically a symptom complex resulting from compression of the neurovascular bundle, that's the artery, the vein, and the nerves all bundled together as it passes through a narrow space called the thoracic outlet between the neck and the shoulder.
And why does the anatomy there become a problem? You mentioned it's a tight fit.
It often is. Nerves, artery, and vein all have to pass through this space, bounded by the first rib, the clavicle, collarbone, and various muscles like the scales. Any slight anatomical anomaly can lead to significant symptoms by compressing one or more of those structures.
What kind of anomalies?
Things like having cervical ribs, extra ribs extending from the neck vertebrae, abnormalities of the scalenus anticus muscle, just the clavicle being too close to the first rib, or an abnormal insertion of the pectoralis minor muscle lower down. Any of these can squeeze the subclavian artery, the subclavian vein, or the brachial plexus nerves.
And it can affect arteries, veins, or nerves differently.
Exactly. Depending on which structures are most affected, it's divided into arterial, venous, and neurogenic forms. Our source material focuses mostly on the arterial aspects here.
So what happens with arterial compression?
Patients with arterial compression might experience claudication in the arm, Raynaud's phenomenon, and in severe cases, even ischemic tissue loss and gangrene in the fingers.
And venous compression?
Venous compression can cause thrombosis or clotting of the subclavian vein. This is sometimes called Paget-Schroeder syndrome or effort thrombosis, often seen in athletes who do a lot of overhead activity.
How do you diagnose it? Is the exam usually normal?
Often, the examination of a patient with arterial TOCS is normal at rest. That's why those provocative maneuvers are so essential. Occasionally, though, you might find decreased or absent distal pulses in the arm or see digital cyanosis and ischemia.
Tell us about those provocative maneuvers. How do they help?
They're designed to deliberately compress the thoracic outlet space, trying to reproduce the patient's symptoms, maybe cause a bruit, a whooshing sound, over the subclavian artery, and diminish the arm pulses. They effectively recreate the compression, giving crucial diagnostic clues.
What are some examples?
There's the abduction and external rotation test, raising the arm out and back. The scaling maneuver, extending the neck, rotating the head towards the symptomatic side. The costoclavicular maneuver, pulling the shoulders back and down. And the hyperabduction maneuver, raising the arm straight up 180 degrees.
What about imaging?
A simple chest X-ray can show if cervical ribs are present. Duplex ultrasonography, MRA, and contrast angiography can be performed while the patient is doing these provocative maneuvers to actually demonstrate the compression of the subclavian artery.
And if nerves are involved?
Neurophysiologic tests like electromyography, EMG, nerve conduction studies, and somatosensory evoked potentials might be abnormal if the brachial plexus is involved. But the diagnosis of neurogenic TOS isn't necessarily excluded if these tests are normal, because they have relatively low sensitivity for this condition.
How is TOCS managed?
Most patients, especially with neurogenic or venous symptoms, can be managed conservatively. They should be advised to avoid the specific positions or activities that cause their symptoms. Many patients also benefit from physical therapy focusing on shoulder girdle exercises and posture.
When is surgery needed?
Surgical procedures, such as removal of the first rib resection, and sometimes resection of the scaling muscles, are occasionally necessary for relief of persistent debilitating symptoms, or especially for treatment of significant arterial compression or ischemia when conservative measures fail.
Okay, another interesting structural issue is popliteal artery entrapment. This one's fascinating, as you said, because it often affects young athletes. The very muscles they use for performance end up causing a vascular problem in the leg.
It's quite paradoxical, isn't it? This condition typically affects young athletic men and women. It happens when the gastrocnemius muscle, the main calf muscle, or sometimes the popliteus muscle behind the knee, is abnormally positioned or inserts in a way that it compresses the popliteal artery during certain movements.
And that compression causes symptoms like PAD.
Yes, it typically causes intermittent claudication pain or cramping in the calf during exercise because the blood flow is restricted when the muscle contracts.
Can it lead to worse problems?
If left unaddressed, chronic compression can damage the artery wall. Thrombosis, clotting, embolism, clots traveling downstream, or even the formation of a popliteal artery aneurysm can occur as complications.
How does the physical exam help here? Are pulses normal?
The pulse examination behind the knee and at the ankle may be completely normal at rest. That's why, similar to TOCS, provocative maneuvers are crucial. Having the patient actively dorsiflex, point toes up, or plantar flex, point toes down, their ankle against resistance can elicit the compression and cause the distal pulses to diminish or disappear.
And diagnosis is confirmed with imaging?
Yes. The diagnosis is confirmed by duplex ultrasound, CTA, MRA, or conventional angiography, often performed both at rest and during those provocative maneuvers to demonstrate the dynamic compression of the popliteal artery.
What's the treatment?
Treatment involves surgically releasing the popliteal artery from the compressing muscle structure. If the artery has already been significantly damaged, vascular reconstruction with a bypass graft might be necessary.
Next, let's talk about popliteal artery aneurysm. You mentioned this can be a complication of entrapment, but it can also occur on its own, right? A sort of silent threat often found behind the knee.
That's right. Popliteal artery aneurysms are actually the most common peripheral artery aneurysms, aneurysms occurring outside the aorta. And interestingly, approximately 50% are bilateral, meaning they occur in both legs.
And there's a link to aortic aneurysms.
Yes, a very strong association. Patients with popliteal artery aneurysms often have aneurysms of other arteries as well, especially the aorta. So what's fascinating here is that finding one popliteal aneurysm should immediately trigger a search for others, particularly an abdominal aortic aneurysm, TIALA. It really highlights the potentially systemic nature of arterial wall weakness.
How do these usually present? Do they rupture often?
The most common clinical presentation is actually limb ischemia, not rupture. This is usually secondary to either thrombosis, the aneurysm clotting off suddenly, or embolism, where clot or debris from within the aneurysm travels downstream and blocks smaller arteries in the lower leg or foot. Rupture does occur, but less frequently than with aortic aneurysms.
Can they cause other problems besides ischemia?
Yes. Other complications include compression of the adjacent popliteal vein, which can lead to DVT-like symptoms, or compression of the nearby peroneal nerve, causing foot drop or sensory changes.
How are they usually found?
Often they can be detected simply by palpation during a physical exam. A careful feel behind the knee might reveal an abnormally prominent or wide pulsation. The diagnosis is then easily confirmed by duplex ultrasonography.
When do they need to be repaired?
Repair is generally indicated for any symptomatic aneurysm, causing ischemia or compression symptoms, or electively when the diameter exceeds about 2 to 3 centimeters. This is because of the significant risk of thrombosis, embolism, or rupture if left untreated. Repair is typically done with bypass surgery, often using a vein graft.
Finally, in the structural category, let's discuss arteriovenous fistulas, or AVFs. You described it as like a dangerous shortcut in the plumbing system. Sounds efficient, maybe, but actually creates a lot of problems.
That's a very apt analogy. Arteriovenous fistulas are abnormal, direct communications between an artery and a vein, which means blood bypasses the normal capillary bed where oxygen exchange usually happens.
And they can be present from birth or happen later.
Exactly. They may be congenital, resulting from persistent embryonic vessels that just failed to differentiate correctly during development. These are often associated with birthmarks, can be located almost anywhere, but frequently occur in the extremities. Or they can be acquired.
How do acquired ones happen?
They're either intentionally created surgically to provide vascular access for hemodialysis.
Ah, the dialysis fistula.
Right. Or they occur unintentionally as a result of a penetrating injury, like a gunshot or knife wound that pierces both an artery and a vein lying close together. They can also occur as complications of arterial catheterization, like during heart caths or during surgical dissection. An uncommon cause is an arterial aneurysm eroding directly into an adjacent vein.
What are the clinical signs? How would you know someone has one?
Frequently, a pulsatile mass is palpable right over the fistula. You can often feel a thrill, a buzzing or vibration, and hear a bruit, that characteristic continuous whooshing sound lasting throughout both systole and diastole with a stethoscope placed over it.
What about effects on the limb?
With long-standing fistulas, especially large ones, clinical manifestations of chronic venous insufficiency become apparent. This is due to the high arterial pressure being transmitted directly into the vein. So you see peripheral edema, large tortuous varicose veins, and stasis pigmentation of the skin.
Can it cause ischemia too? Seems counterintuitive with more flow.
Paradoxically, yes.
Yeah.
Evidence of ischemia may occur in the distal portion of the extremity because the high flow through the fistula effectively steals blood away from the downstream capillary beds. Also, the skin temperature is usually higher right over the arteriovenous fistula itself.
Can large ones affect the heart?
Yes, very significantly. Large arteriovenous fistulas can shunt so much blood back to the venous side that it dramatically increases the volume load on the heart. This can lead to an increased cardiac output, subsequent cardiomegaly, enlargement of the heart, and eventually high-output heart failure.
How is the diagnosis made?
Often the diagnosis is pretty evident just from the physical examination findings, the palpable thrill, the continuous bruit. There's also a classic physical sign called the Nicoledoni-Branham sign. Temporarily compressing the artery leading into a large fistula may cause a reflex slowing of the heart rate as the cardiac preload suddenly decreases.
Can imaging help?
Duplex ultrasonography is very useful for detecting an arteriovenous fistula, especially one affecting the femoral artery and vein at a common catheter access site in the groin. CTA and conventional angiography can confirm the diagnosis and are particularly useful in demonstrating the precise site and size of the fistula, which is important for planning treatment.
And how are they managed?
Management can involve surgery, radiotherapy in some cases, or endovascular embolization.
Is it different for congenital versus acquired?
Yes, congenital fistulas are often very difficult to treat because the abnormal communications may be numerous and extensive, involving many small vessels. And new communications frequently develop even after ligation of the most obvious ones. Many of these lesions are best treated conservatively, perhaps using elastic support hose to manage the consequences of venous hypertension. Occasionally, embolization with autologous material like fat or muscle, or with hemostatic agents like gelatin sponges or silicon spheres, is used to try and obliterate the fistula.
And acquired ones?
Acquired fistulas are usually more amenable to surgical treatment. This typically involves division or excision of the fistula itself. Occasionally, autogenous vein or synthetic grafting is necessary to reestablish continuity of both the artery and the vein after the fistula is removed. #6, vascular responses to environment and systemic conditions, skin deep clues.
All right, finally, let's explore a group of conditions that often reveal themselves in sometimes quite dramatic ways right on the skin, frequently in response to temperature changes or as clues to underlying systemic issues.
Right.
These conditions really remind us that the extremities, fingers, toes, hands, feet, are often the first places to show signs of deeper, perhaps more widespread problems.
That brings us to Raynaud's phenomenon.
Right.
And the question it raises is, why these dramatic, distinct color changes? It's really a vivid demonstration of the body's sometimes exaggerated vascular response to cold or stress. And crucially, identifying the underlying cause is vital because secondary Raynaud's can often be a harbinger, an early sign of a serious systemic disease, which significantly impacts both treatment and prognosis.
So Raynaud's is characterized by episodic digital ischemia, right? Temporary lack of blood flow to the fingers or toes.
Exactly. It manifests clinically by the sequential development of digital blanching, whiteness, then cyanosis, blueness, and finally rubo-redness of the fingers or toes, typically after cold exposure and then subsequent rewarming. Emotional stress can also precipitate an episode in some people.
And the color changes are pretty distinct.
Usually very well demarcated, yes, and confined to the fingers or toes. The initial blanching or pallor phase, where one or more digits appear white, represents the ischemic phase due to vasospasm of the digital arteries. This phase is often accompanied by a sensation of coldness, numbness, or paresthesia, tingling.
And then it turns blue.
During this ischemic phase, the capillaries and venules downstream actually dilate, and cyanosis, that bluish discoloration, results from the deoxygenated blood pooling in these dilated vessels.
And finally red.
Yes. With rewarming, the digital vasospasm resolves, blood flow rushes back into those dilated arterioles and capillaries. This is called reactive hyperemia, and that imparts a bright red color, the rubor, to the digits. Along with the redness and warmth, patients often experience a throbbing, sometimes painful sensation during this hyperemic phase.
Does everyone get all three colors?
While this triphasic color response is typical, some patients may develop only pallor and cyanosis, others might just experience cyanosis.
And it's divided into primary and secondary types.
Correct. Raynaud's phenomenon is broadly separated into two categories. Primary Raynaud's phenomena, which used to be called Raynaud's disease, where it's idiopathic, meaning no known underlying cause.
Okay.
And secondary Raynaud's phenomena, which is associated with other disease states or known causes of vasospasm.
Tell us about primary Raynaud's.
This diagnosis is applied when secondary causes have been carefully excluded. Over half of patients presenting with Raynaud's symptoms have this primary form. It affects women about 5 times more often than men, and the age of presentation is usually between 20 and 40 years.
Where does it usually affect?
The fingers are involved much more frequently than the toes, although toes are affected in about 40% of patients, usually along with finger symptoms, but sometimes alone. Initial episodes might involve only one or two fingertips, but subsequent attacks may involve the entire finger and eventually all fingers. Rarely the earlobes, the tip of the nose, tongue, nipple, or even the penis can be involved.
Are there other associated conditions?
Interestingly, primary Raynaud's phenomenon occurs frequently in patients who also have migraine headaches, variant angina, Prinzmetal's angina, or pulmonary hypertension. This suggests there might be a common underlying predisposing cause for vasospasm in these individuals.
What does the physical exam show?
Often the results of the physical examination are entirely normal between attacks. The radial, ulnar, and pedal pulses are normal. The fingers and toes might feel cool between attacks and may perspire excessively.
What about looking at the capillaries?
Nail fold capillaroscopy, where we examine the tiny capillaries at the base of the nail fold under magnification, reveals normal superficial capillaries in primary Raynaud's. They appear as regularly spaced, knead hairpin loops.
Any skin changes?
Thickening and tightening of the digital subcutaneous tissue, known as sclerodactyly, develops in about 10% of patients with long-standing primary Raynaud's. But importantly, diagnostic angiography of the digits is not indicated for primary Raynaud's.
What's the prognosis like?
In general, patients with primary Raynaud's have milder clinical manifestations compared to secondary. Fewer than 1% of these patients ever lose a part of a digit. After diagnosis, the disease actually improves spontaneously in about 15% of patients, while it progresses in severity or frequency in about 30%.
Okay, now what about secondary Raynaud's phenomenon? You said it's linked to many other conditions.
Yes, a huge number of connections here. One major category is collagen vascular diseases. Raynaud's occurs in a striking 80–90% of patients with systemic sclerosis, scleroderma.
That high, wow.
Yes, and it's the presenting symptoms in about 30% of scleroderma patients. It gets to sometimes be the only symptom for years before other features develop. In scleroderma, it can be very severe, leading to ischemic fingertip ulcers, gangrene, and even autoamputation due to the underlying structural abnormalities in the digital vessels.
What about lupus?
About 20% of patients with systemic lupus erythematosus, SLE, have Raynaud's phenomenon. They too can develop persistent digital ischemia, ulcers, or gangrene, often due to a proliferative endarteritis, occluding small vessels. It also occurs in about 30% of patients with dermatomyositis or polymyositis, and frequently develops in patients with rheumatoid arthritis, possibly related to intimal proliferation in their digital arteries.
Can blocked arteries themselves cause it?
Yes, arterial occlusive diseases are another important cause. Atherosclerosis of the extremities is a common cause in men aged over 50. Thromboangiitis obliterans, Buerger's disease, as we discussed, is a significant cause in young male smokers. Raynaud's can also follow acute occlusion of large and medium-sized arteries by a thrombus or embolus. And atheroembolic debris showering down to the digits can cause digital ischemia, often affecting just one or two digits, which needs to be distinguished from classic Raynaud's.
What about structural or nerve issues?
Thoracic outlet compression syndrome can trigger Raynaud's, either by diminishing intravascular pressure or perhaps through sympathetic fiber stimulation. It's also associated with pulmonary hypertension, maybe reflecting a shared dysfunction in vascular smooth muscle regulation. Various neurologic disorders can be linked, like intervertebral disc disease, syringomyelia, spinal cord tumors, stroke, poliomyelitis, carpal tunnel syndrome, or complex regional pain syndrome.
Blood disorders, too.
Yes, certain blood dyscrasias can cause it. Conditions associated with cold agglutinins, cryoglobulinemia, or cryofibrinogenemia, where plasma proteins precipitate in the cold, can lead to hyperviscosity and red cell or platelet aggregation, triggering Raynaud's. Myeloproliferative disorders like polycythemia vera or essential thrombocytosis and lymphoplasmacytic lymphoma can also cause hyperviscosity-related Raynaud's.
And physical trauma?
Trauma is a big one, especially occupational. Vibration injury from using tools like jackhammers or chainsaws is a well-known cause, vibration white finger. Hammer-hand syndrome, repeated impact of the palm, electric shock injury, frostbite, and even repetitive motions like typing or piano playing have been implicated.
Lastly, drugs and toxins.
Yes, several drugs and toxins are associated. Ergot derivatives used for migraines, methizergide, beta-adrenergic receptor blockers, though usually mild, certain chemotherapeutic agents like bleomycin, vinblastine, cisplatin, and gemcitabine, and exposure to vinyl chloride.
So with all those potential causes, how is Raynaud's treated?
Treatment depends on the severity and whether it's primary or secondary. For most patients, especially with primary Raynaud's, the episodes are mild and infrequent. For them, conservative measures are key. Reassurance is important. They should be instructed to dress warmly, especially in layers, and avoid unnecessary cold exposure. Protecting not just the hands and feet, but also the core body, trunk, head, and feet with warm clothing is important to prevent cold-induced reflex vasoconstriction throughout the body. And absolutely, tobacco use is contraindicated.
When is drug treatment needed?
Drug treatment is reserved for patients with more severe or frequent episodes, or those developing complications like digital ulcers, often seen in secondary Raynaud's.
What drugs are used?
The mainstays are calcium channel antagonists, specifically the dihydropyridine type, like nifedipine, isradipine, philodipine, and amlodipine. These decrease both the frequency and severity of attacks. Diltiazem, another calcium channel blocker, may be considered, but is generally less effective for Raynaud's.
Any other options?
Alpha-adrenergic antagonists, particularly the postsynaptic alpha-1 blocker prazosin, have been used with favorable responses. Others in that class, like doxazosin and terazosin, may also be effective. Phosphodiesterase type 5 inhibitors drugs like sildenafil, tadalafil, and vardenafil, used for erectile dysfunction, may improve symptoms, especially in patients with secondary Raynaud's phenomena, for example, related to systemic sclerosis. There's also evidence that topical nitroglycerin preparations applied to the digits can be effective.
What if medications don't work?
For very severe refractory cases, digital sympathectomy, surgically cutting the sympathetic nerves to the digits, can be helpful in some patients. More recently, injection of botulinum toxin into the perivascular tissue of the wrist or palm has shown promise in improving ischemic manifestations in case series, but controlled clinical trials are still lacking.
Okay, moving on to acrocyanosis. You mentioned earlier, if someone's hands or feet are persistently blue but otherwise seem fine, it might be this. It sounds like a key lesson in not jumping to the most alarming conclusion immediately.
That's a very important point in clinical practice. Context is everything. In acrocyanosis, there's arterial vasoconstriction happening, but also a secondary dilation of the capillaries and venules downstream. The net result is persistent cyanosis, that bluish discoloration primarily of the hands, and less frequently the feet. Cold exposure can definitely intensify the blueness.
Is it always benign?
Acrocyanosis can be categorized as primary or secondary to an underlying condition. Primary acrocyanosis is the benign form. It affects women much more frequently than men, and the age of onset is usually under 30. Patients are generally asymptomatic, but seek medical attention simply because of the discoloration. The key is that the prognosis is favorable. Importantly, pain, ulcers, and gangrene do not occur.
What does the exam show?
Examination reveals normal pulses, peripheral cyanosis, and often the palms are cool and moist. Crucially, there are no trophic skin changes like thinning skin or hair loss, and no ulcerations.
How is it different from Raynaud's?
It can be distinguished from Raynaud's phenomenon because acrocyanosis is persistent, not episodic. Also, the discoloration typically extends proximally from the digits, maybe up the wrist or ankle, whereas Raynaud's is usually sharply demarcated at the fingers or toes. And importantly, the blanching phase seen in Raynaud's does not occur in acrocyanosis.
And how do you rule out more serious causes of blue extremities?
Ischemia secondary to arterial occlusive disease, like PAD, can usually be excluded by the presence of normal pulses. And central cyanosis, due to lung or heart problems causing low oxygen saturation in the blood, is not present.
So, treatment for primary acrocyanosis.
Patients should simply be reassured about the benign nature of the condition and advised to dress warmly and avoid cold exposure. Pharmacologic intervention is not indicated.
What about secondary acrocyanosis?
Secondary acrocyanosis can occur. It may result from severe hypoxemia, exposure to certain vasoconstrictive drugs, and interestingly, it's associated with conditions like anorexia nervosa and postural orthostatic tachycardia syndrome, POTS. In these cases, treatment should be directed at the underlying disorder.
Okay, another visually distinctive condition is levato-reticularis. This one presents as a mottled, almost net-like or lace-like pattern on the skin, right?
Exactly. And the question it raises is, what causes that distinctive pattern? It's often related to sluggish blood flow in the superficial capillaries and venules of the skin, but the underlying causes, much like Raynaud's, can range from completely benign to quite serious. So differentiating primary from secondary forms is absolutely key for accurate management.
Describe the appearance again.
In levato-reticularis, localized areas of the extremities develop this mottled or rete, meaning net-like appearance, with a reddish to blue discoloration. And again, there are primary and secondary forms.
What's the primary form like?
The benign or idiopathic primary form occurs more frequently in women than men, with the most common age of onset being the third decade. The modeling pattern is typically symmetric and uniform in appearance. It may become more prominent after cold exposure and tends to improve with warming.
Are patients symptomatic?
Patients with this benign form are usually asymptomatic and seek attention mainly for cosmetic reasons. Treatment involves reassurance and advising them to avoid cold environments. No drug treatment is indicated.
Is there a more serious primary form?
Yes, there's a variant called primary livedo-reticularis with ulceration, also known as atrophy blanche en plaques. In this condition, painful ulcers develop within the areas of livedo, and these ulcers can take months to heal.
Now, what about the secondary form?
Secondary livedo-reticularis is sometimes termed livedo-racemosa. This term is used when the modeling pattern is irregular, maybe broken or starburst-like, and crucially, it does not improve significantly with warming. Rarely, skin ulcerations can develop in this form as well.
And what causes secondary livedo?
This secondary form can occur with various potentially serious underlying conditions. These include atheroembolism, remember the microdebris, systemic lupus erythematosus, SLE, and other systemic vasculitides, antiphospholipid antibody syndrome, hyperviscosity syndromes, cryoglobulinemia, and Sneddon syndrome, that rare combination of ischemic stroke and livedo-reticularis. Finding livedo-racemosa should prompt a workup for these underlying causes.
Next up, pernio, which most people probably know as chilblains. It sounds common enough, but you're saying it's actually a form of vasculitis, an inflammatory condition of the vessels brought on by cold.
That's the key distinction, yes. Pernio is fundamentally a vasculitic disorder associated with exposure to cold. Acute forms have definitely been described, especially recently with some viral infections, but classically it's related to damp, cold exposure.
What do the lesions look like?
Typically, raised erythematous, red or purplish lesions develop, most commonly on the toes or fingers, but sometimes ears or nose, usually appearing hours after cold exposure in susceptible individuals. They are often dissociated with significant pruritus, itching, and a burning sensation. Sometimes they may blister or even ulcerate.
And pathology shows inflammation.
Yes, pathologic examination demonstrates angiitis inflammation of small blood vessels characterized by intimal proliferation, thickening of the inner lining, and perivascular infiltration of mononuclear and polymorphonuclear leukocytes, types of white blood cells. Giant cells might even be present in the subcutaneous tissue.
How is it treated?
The most important thing is for patients to avoid exposure to cold and damp conditions. Any ulcers that form should be kept clean and protected with sterile dressings to prevent infection. Some medications may be effective in certain patients, particularly for recurrent or severe cases. These include sympatholytic drugs or dihydropyridine calcium channel antagonists like nifedipine, which can help improve blood flow.
Okay, now let's talk about erythromelalgia. This condition is really known for its intense burning sensation and redness, right?
Exactly, and it raises the question, what is it about the triggers, usually warmth, that causes such intense burning pain? It seems to be related to a dysfunction in the small sensory nerve fibers and vascular regulation in the skin, highlighting a different aspect of neurovascular control. The genetic link found in primary forms is particularly fascinating from a research perspective.
Describe the condition again.
Erythromelalgia is characterized by burning pain and erythema, redness of the extremities. The feet are involved more frequently than the hands, and interestingly, males are affected more frequently than females, which is different from Raynaud's and acrocyanosis. It can occur at any age, but is most common in middle age.
And it can be primary or secondary?
Yes, it may be primary, sometimes termed erythromelalgia, or secondary to an underlying condition.
Is the primary cause known?
For some inherited forms of primary erythromelalgia, yes. Mutations have been described in the SCN9A gene. This gene encodes a specific voltage-gated sodium channel, Nav1.7, which is expressed in sensory and sympathetic nerves, providing a direct link between nerve excitability and the symptoms.
What about secondary causes? What's it linked to?
The most common causes of secondary erythromelalgia are myeloproliferative disorders, particularly polycythemia vera and essential thrombocytosis. It can be an early clue to these conditions.
Any other causes?
Less common causes include certain drugs, like some calcium channel blockers, bromocriptine and pergolide, various neuropathies, connective tissue diseases like SLE, and occasionally perineoplastic syndromes associated with underlying cancers.
What triggers the symptoms?
Patients typically complain of intense burning in the extremities that is precipitated or worsened by exposure to a warm environment, the opposite of Raynaud's. It's also often aggravated by a dependent position, like standing or walking.
And how do they get relief?
Characteristically, the symptoms are relieved by exposing the affected area to cool air, or immersing it in cool water, or by elevation.
How do you distinguish it from ischemic pain, like from PAD?
That's a crucial distinction. Erythromelalgia can be distinguished from ischemia secondary to peripheral arterial disorders because the peripheral pulses are present and usually normal. The problem isn't lack of blood flow overall, but abnormal vascular reaction and nerve signaling.
Is there a specific treatment?
Unfortunately, there is no single specific treatment that works for everyone, especially for the primary form. However, aspirin may produce dramatic relief in patients whose erythromelalgia is secondary to a myeloproliferative disease. Topical anesthetics might be considered to help relieve pain locally. And, of course, treatment of any associated underlying disorder in secondary erythromelalgia may be helpful.
And finally, we come to frostbite. This seems like a very clear example of how the environment directly impacts our vascular health and tissues. And the material emphasizes knowing the right way and the wrong way to treat it initially.
Yes, initial management is absolutely critical in frostbite to minimize long-term damage. Frostbite involves tissue damage resulting directly from severe environmental cold exposure or from direct contact with a very cold object like metal. The injury results from a combination of ice crystal formation within the tissues, actual freezing, and profound vasoconstriction, shutting down blood flow.
Where does it usually occur?
It typically affects the distal aspects of the extremities, fingers and toes, or exposed parts of the face, such as the ears, nose, chin, and cheeks.
Are there different degrees of severity?
Yes, it's generally classified into types based on depth. Superficial frostbite involves the skin and subcutaneous tissues. You might see cyanosis and redness, swelling, edema, maybe some superficial blisters, and often numbness followed by burning or tingling on rewarming.
And deep frostbite.
Deep frostbite is much more serious, involving muscle, nerves, and deeper blood vessels. It may result in significant edema of the entire hand or foot, large vesicles and hemorrhagic bullae, blood-filled blisters, and ultimately tissue necrosis and gangrene, potentially leading to limb loss.
What is the crucial first step in treatment?
Initial treatment is rapid rewarming. This must be performed in an environment where re-exposure to freezing conditions will not occur. Rewarming is best accomplished by immersing the affected part in a circulating water bath heated to temperatures between 40 degrees and 44 degrees C. That's 104 degrees to 111 degrees RF.
What should absolutely not be done?
Crucially, things like rubbing the affected area with snow or hands, applying ice water, or using extreme dry heat, like from a fire or heating pad, are contraindicated. These can cause further tissue damage. Gradual rewarming at room temperature is also less effective than rapid water bath rewarming.
What happens after rewarming?
Ongoing care involves gently cleansing the injured area with soap or antiseptic and applying sterile, non-adherent dressings, often with elevation to reduce swelling. Analgesics are usually required during the rewarming process, as it can be intensely painful. Antibiotics are used if there is evidence of secondary infection.
Do other treatments help?
The efficacy of sympathetic blocking drugs or other vasodilators is not clearly established for improving outcomes in frostbite. Sometimes specialized treatments like thrombolytics are considered in very severe early cases involving major limb threat, but that's controversial.
What are the long-term effects?
After recovery, the affected extremity often exhibits increased sensitivity to cold, persistent pain, numbness or altered sensation, and an increased risk for future frostbite. It can leave lasting consequences. #tag outro.
Wow, what an incredible journey that was, navigating through Chapter 281 on arterial diseases of the extremities. We've really covered a vast territory here.
We certainly have.
Everything from those inflammatory conditions affecting the body's main pipeline, the aorta, to the huge systemic impact of PAD. And then all those fascinating, sometimes rare conditions that give us clues right there on the skin.
Indeed. From understanding the nuanced pathology of the different types of aortitis to really grasping the critical importance of risk factor modification and the complexities of revascularization in PA. And then delving into these unique vascular syndromes like FMD, Buerger's, Raynaud's, and the others. You should now have a really comprehensive, almost professional level understanding of just how diverse these arterial challenges can be.
You've hopefully achieved that elite level of understanding of this material, a true shortcut, perhaps, to being really well informed on this vital topic. So here's a final thought for you, the listener, to maybe mull over. Considering the sheer variety of causes and presentations we've explored today, from, silent inflammation deep inside, to micro debris causing blue toes, to anatomical squeezes, to those dramatic skin changes, What implications do you think this deeper understanding has for how we approach preventive health and maybe even personalized medicine?
That's a great question.
How might it change how we recognize the earliest, perhaps most subtle signs of arterial disease in our daily lives or in clinical practice, prompting us to look beyond just the most obvious symptoms?
Food for thought, definitely.
Keep digging, keep learning, and thank you for joining us for this deep dive.